Here are today's episode highlights.
Comadres Unfiltered.
Yay!
Activated. Yay! So if you have been feeling foggy, overwhelmed, give me symptoms.
Sleepless, insomnia,
Hip pain,
hot
tinnitus,
flashes.
Frozen shoulder.
Guess what? You're not alone. Woohoo!
Every single person born a woman goes through perimenopause
Yeah,
and
that's
menopause.
right.
Every woman.
Without further ado, let's welcome our fifth comadrita, Dr. Karen Mann. Yay!
All right.
We are so happy you are here today with us.
Are we too loud for you?
Oh, bring it. I can handle it. Yeah.
Please, just be yourself. In Spanish, we say, estás en casa.
For me, obviously, I'm going through it myself. I'm right there. And I figured as a women's health specialist, it would really be silly for me not to focus.
Other experts that it's kind of like a very brief chapter in school, and it's like, yeah, women go through menopause, blah, 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 and moving on.
Yeah.
How sad.
Menopause, I think, is getting a little bit more intense.
Oh.
We have to work harder to be healthier these days than we ever had.
Yeah.
And
So it's not just in our head.
no.
We feel lately that we're the ones advocating for knowing more with our doctors, and they're either shutting us down by saying, you're too young for that.
I don't know what's next. Like, what do I do? Do I go into supplements? Do I explore HRT? I mean, she was very condescending.
How do
Find
we know
out.
that we're on perimenopause? So,
Okay,
yeah.
I need water for this.
Yes. We don't need water for this. Okay, this is where it gets
Roll up the
good, girl.
sleeves. A cream? Is it a pill? Is it a patch?
Now, what is HRT?
Yes.
Hormone
Okay,
replacement therapy.
Comadres. And then the progesterone kind of calms it down and keeps it level and balanced. So
6'7".
Yeah, 6'7". Oh my God.
I had to say that.
When you talk about menopause, it means that you're freaking old. You're old.
Yeah.
So
Yes.
nobody wants. It's so taboo.
Girls, you guys want to touch pellets?
Yes.
And men, don't go through this.
No.
Well, maybe they do, but not at this level.
Can I say they don't go through it because they can't handle it?
Yeah.
Probably.
People are doing like microdosing GLP-1s.
Yes.
What is that all about?
Exactly.
And how does that help perimenopause and menopause?
Hair loss. You know, our hair is our crown.
Yes.
Our hair is everything.
Yes.
So we have comadritas literally crying. I am crying as I write
I'm
this.
crying also.
If you are a woman, check. This is the episode you have to
Yes.
watch.
Check, check, check.
Hey girl, welcome. We've been waiting for you. Bienvenida. We are four comadres and we are so excited to have you here. I am Argelia.
I am Mindy.
I am Diana.
And I'm Janet. Join us. Grab that drink. Get comfy, settle in, and get to know us.
As we get down with some real conversations.
And raise that glass to the true power of sisterhood.
Are you ready for us?
This is Comadres Unfiltered.
Salud!
I just noticed I'm the only one drinking hot tea.
Ooh, you got the memo. Well, no, you didn't get the memo.
I didn't bring. Well, I know. I just
bling
thought
bling.
I'm cold.
It's okay.
It is, you know,
Con
at the-
piquete.
El piquetito, yeah. I want to know what's in that mug, D. The day that we're taping this episode, it is freaking cold. The sky is falling. The sky is falling. Remember that when you were little?
Yes.
Remember
Yeah.
Chicken Little?
Yes.
The sky is falling. The sky is falling. The
sky's
sky is
falling.
literally falling. But here we are, feeling cozy. Comadres Unfiltered.
Yay!
Activated. Yay!
Section.
And
Here we
actually,
go.
I should be the one drinking hot tea because I have these really bad allergies.
Who are you?
I know.
This
That
voice.
voice is sexy.
Girl, you need to
Yeah.
take advantage of this. And do those 1-800 numbers.
My voice is already very deep, so now you add another layer of that, you know?
Oye, Di, ahora sí dame un grrr.
I know.
I hope you feel better. Honestly, un aplauso a la Coma Mindy.
Yes.
You're a trooper. She's been under the weather for a few days. And the fact that you showed up today knowing that you're still not completely out of the woods, but man.
Well, you know why I showed up.
It's
Because
one of our
today's
favorite topics.
episodes
Yes.
is one of my absolute favorite topics to talk about. So
worth
such
it.
an important topic.
So worth it. And I'm glad that you bring that up, Coma, because yes, we have heard you, comadritas. Our community since day one has asked about perimenopause and menopause, where some of us were in denial that we were in the phase.
That would be us.
That would be me too.
Yeah.
When we started this project, I was going through it without knowing that I was going through it. I just thought I was just
Right.
being, one of those crazy mom moments. But it's actually it was linked to perimenopause.
Right.
But we've heard you loud and clear. And finally, season 3, we're touching it. So if you have been feeling foggy, overwhelmed, give me symptoms.
Sleepless, insomnia,
hip pain,
hot
tinnitus,
flashes,
Frozen shoulders.
Yes.
Hot flashes.
hot flashes,
weight gain.
weight gain, cold flashes, anything.
Belly gain.
Right. Okay, if you've been feeling any of those symptoms, guess what? You're not alone. Woohoo! You're not crazy.
alone.
You're not alone. You are not imagining it.
You're just a
because-
woman.
Yeah,
Going through
thank you.
Perimenopause or menopause.
Yeah.
You don't have to suffer through it. This
I
is
know.
what today is all about.
Exactly.
Like, I want to know more.
And
I know
something
you
that's
guys do
really
too.
important to note is that every single person born a woman goes through perimenopause
Yeah,
and
that's
menopause.
right.
Every
That's-
woman, and it doesn't matter if you've had babies or not, or what you're going to go through.
Yes. And
In your own way, right?
Yes.
In your own way, but
Yeah.
you will.
And that's the common denominator. We're just women, and God made us this way. And so I do have questions, okay? I do have questions. But these changes are real. And today, finally, we're going to have this convo with an expert who's going to break it all down for us with clarity and truth and dismantling some myths. Because, you know, sometimes we hear things from our tias, which know not a lot compared to this generation where we're more aware of the research and the new findings. But I'm really excited to welcome our amazing guest, Diana. I got to give it to you, girl. I don't know how you found her, but you found her. I'm going to give you all the credit in the world. Un aplauso para ti, because she hunted
Thank you.
down this incredible women's health specialist whose work empowers women to understand their bodies, advocate for themselves, and navigate midlife with confidence and dignity. Así que, comadritas, grab your tea or your cafecito or anything that you want.
Grab your pen.
And your
Yes,
pen.
and your pen.
A notepad, right? Se va a poner buena la cosa. So, without further ado, let's welcome our fifth comadrita, Dr. Karen Mann. Yay!
All right.
We are so happy you are here today with
we are.
us.
Bienvenida.
Thank you.
Welcome.
The fifth comadre.
Yes.
Are we intimidating you? Are we too loud for you?
Oh, bring it. I can handle it.
Yes.
Please, just be yourself. You're in Spanish. We say "estás en casa."
Yes.
You're at home.
Yes.
So,
yes.
how was the drive? Because I know that your practice is not here in LA.
Yeah, I live in San Diego, so it was not bad. We came up a couple of days ago and before the rain really started. So
Oh, that's great.
I made it, no problem.
Yay,
Okay.
safe and sound.
It all worked out.
Amazing.
She's
Yeah.
here.
I'm
That's
here.
awesome.
So
happy to be here.
We gotta ask before we even dive into this deep convo. ¿Cómo está tu español? ¿Nos entiendes? ¿Sabes una mala palabra? ¿Una buena palabra?
Si habla despacio, puedo entender.
Ok.
Pero cuando hablas muy...
Janet, no hables rápido, ¿eh?
Slow it down, girl.
Slow it down. Slow it down.
Yeah. Learning new words every day. So whatever you got, give it to me. I'll do
All right,
my
we're going
best.
to quiz you when you leave, what you learned while you were here.
Well, the first word she has to know is comadres.
Yes.
Comadres.
Right?
Yeah.
There we go.
I got it.
Comadres. Do you know the meaning of comadres?
Well, it's like compadres, but
Yes.
for women.
Yes.
Yes.
Camaraderie, you know, sisterhood.
Yes.
Right. Really,
Yeah,
that's
I
what
love
it
it.
is.
Yeah.
So today you are fifth comadre. And I have, I don't know, I kind of heard that you grew up in LA or this area. So you're not new to the LA area.
No, not at all. I consider this home. This feels very comfortable
that's
to me.
great.
Yeah. I grew up just over the hill in Thousand Oaks. I actually did, some college here, UCLA. Had my residency was on Sunset Boulevard in Hollywood.
that's
So very
great.
much in Angelina.
Oh, so there's something in common here.
Bruin, fellow Bruin. Yes.
Great.
Fellow Bruin.
Oh, wow.
You know, since we're digging into your background, I would love to know, your focus was obstetrician, was your focus. But what made you really dive into the specialization in menopause and perimenopause?
Well, selfishly, I feel like a lot of doctors go into things that are relevant to them or interested in things that have to do with their own journey. So for me, obviously, I'm going through it myself. I'm right there. And I figured as a women's health specialist, it would really be silly for me not to focus more energy on this. So I went back and did the menopause certification so that I would have all the information. And even that's not enough, though. Even that I've had to do a lot of extra reading and just talking to many people, my fellow obstetricians, and learning how they practice. And so I've got a lot of information from multiple different sources to help inform how I talk to patients.
And is that because there wasn't a lot of information out there to begin with? Is that what you've been
let me tell you, we did not learn anything. And I don't know if you've heard this from other doctors, but they all will say, like, when I trained, we didn't learn any of this stuff. So that's why it's even more important for people like me and other doctors to be out there doing their own work so that they can learn it now. And that's what we've all had to do. It just wasn't talked about.
I was just about to ask you that because I've heard from other specialists, other experts that it's kind of like a very like brief chapter in school, and it's like, yeah, women go through menopause, blah blah blah, and moving on.
Yeah,
and
How
so
sad.
it's great. Yeah,
How dismissive it was, right?
It really is.
Absolutely.
And I think this is my own theory, but I think as our lives become more complex and stressful and there's more demands on us and social media and all the things, menopause, I think, is getting a little bit more intense. I think our bodies are a little bit more inflamed than they've ever been. Really? And so I feel like it shows up, it's more prominent now than it has been in the past. So I think we need to address it. We need to think about it differently than than our moms had to.
Yes.
And yeah, that's what we're doing.
Why
and
do you
you're
think
part of
it's-
that, all of you.
Why do you think it's more intense now?
Just because of how metabolically challenged we are. We live in a society that does not really emphasize healthy practices. Our food community is just fast food everywhere and eat on the go. And that's not how humans were supposed to be. So I always talk in terms of like evolution and where we came from and how we got here. And what we're doing now is so mismatched with what humans were supposed to do with their bodies and with their health. And I think that adds to metabolic dysfunction. And we see that in the rates of diabetes and overweight. I'm also an obesity medicine specialist. Again, for my own journey, I struggled with my weight my whole life. So I wanted to learn like the medical perspective of it so that I would understand it better. But as I was saying, we're overweight, we're obese, we're metabolically unhealthy, and all of that because menopause is somewhat of an inflammatory time, just with the loss of estrogen. Estrogen being an anti-inflammatory hormone. When it goes away, we become more inflamed. Couple that with all of the things in our lifestyles that are not necessarily supportive. Like we have to work harder to be healthier these days than we ever had.
Yeah.
And
So it's not just in our head.
no.
It really truly is. We have to work harder. I always say that there was kind of like a break every 5 years after 25 in just the way my body processed food and in the way that, I responded to working out or just movement. What worked for me at 25 did not work for me at 30. Definitely didn't work at 35. So it's just you have to eat less. You have to change your diet. And also work out more.
And it's not even about eating less. It's eating the right foods. It's actually eating more protein.
Yeah,
Right.
not
It's not eating less.
romanticizing food anymore.
Exactly.
Not going for the pizza and the burgers. Now it's like your
healthy.
protein, your healthy
Protein.
your fish,
Exactly.
your.
But I love what you guys are bringing up. We're more mindful of our eating habits.
Yes.
How it's connected and related to, this stage in our life, perimenopause and menopause. But let's take it back to I'm just curious to what you said that you had to go back and get certified, which we commend you for that. Because a lot of doctors, in OBGYNs, even though they know there's more information, they're still not taking a step back to, okay, let me go get some certification so that when my patients come, I know what to tell them, right?
Exactly.
Because we feel lately that we're the ones advocating for knowing more with our doctors, and they're either shutting us down by saying, you're too young for that, or you're just hearing it because it's a trend, or you're not there yet, don't worry about it. Or they just don't want to admit that they're not educated or re-educating themselves, right? That's the reality.
Yes, absolutely. So this is the time where we have to be our own advocates. And we learn that doctors kind of learn everything, know everything, are going to show up for you no matter what. It's not really the case. You have to bring the knowledge that you have, and we have to start educating our doctors. And I know that's a little bit scary, but if you show up with the mindset that they can receive it and hear it and come and say, I need your help, will you help me? How could you say no as a doctor? We went into this work to help people. If you come to us with an open heart, with curiosity, and not with anger and I've been wronged and why don't you know this, you're going to open your doctor's heart and they're going to be there to help you and they're going to be motivated to learn because that's what needs to happen.
Yeah.
And it doesn't always happen. You come, this is a personal anecdote actually, and we've been through this podcast and we did talk about menopause. We touched it. And so I started to explore more about what was going on with my body because there were a few of those symptoms that I ticked off. And I did go to my doctor and we have a great relationship. And I brought up menopause. I mentioned the specific symptoms that I have. And then I said, I don't know what's next. Like, what do? Do I go into supplements? Do I explore HRT? And she told me, I mean, she was very condescending, I want to say, because, I did bring up the podcast and the books that I've been reading. And she's like, oh, that's a trend. Like, oh, I don't, don't listen to all of that. The other part of it that shook me was that she told me, like, don't look at HRT. Do you want to get cancer?
Literally.
And this is a doctor that you have a good relationship
And
with.
female.
And a female who's already gone through menopause herself.
That is awful.
And she said, you want to get cancer? I'm like, wait a minute. I've read that progesterone teamed up with estrogen.
Yes.
It has been proven not to. She's like, yeah, but the research hasn't been really complete. Anyway, so my point is that you do go and advocate for yourself, and you are met sometimes with roadblocks. So what do we do when that happens?
You change the doctor.
Well,
That's
that's
what you do.
to start.
Thank you.
Go see
I was going
somebody
to say,
else
get out.
To start,
who has education, right?
Right.
Or you go to another somebody else, like a platform like Noom, right?
Yes,
Which
absolutely.
you have an association with Noom.
Yes,
Right?
Yes. I'm the medical director at Noom.
Okay.
So,
That's
yeah,
amazing.
we definitely have many users that are women. So, I come from that perspective of wanting to help, hundreds of thousands of users through their weight loss journey with the mindset of what is needed additionally as a woman on that journey, especially during this time of our lives when it seems to be like such a challenge to manage your weight. And we do have, hormone therapy available. And so, if people are curious about it, they can check us out and see if that's something that might work for them. But to your point, there are so few providers that are menopause certified, although I will say the numbers are growing. And I was just at the menopause meeting in Orlando, and there are 12,000 members now when it used to be 1,000 or less.
12,000.
There were
So
1,000
it's
of us
grown.
plus at this meeting, and there used to be like 200. So we're getting
Well,
there.
that's hopeful.
It's getting
Yes.
better.
That's
Don't
great.
give up.
Yeah.
For the comadritas that don't know what Noom is, what exactly is Noom?
Noom is an online digital health and wellness platform that in its inception was for weight management. And it was really the first large-scale organization that looked at weight loss from the mind. So it was psychology-based. It's cognitive behavioral therapy-based, because you can count your calories all you want. You can track all you want. But if you're not thinking the right way about what that change means for you, what your deep why is, it's not going to stick.
That's true.
So that's where we come from. And I was a Noom client user before I even became affiliated with them as their medical director. So I did the program. I lost 40 pounds. I have kept it off. And I think it works really well when you couple how you think of what you're doing with what you're doing. It's the most effective way to do it.
But I think the greatest part about that is that you do pair it up with perimenopause or with other options of what people are going through and how they're addressing, their weight gain, whether it's through perimenopause or it's psychological, right? And
Yeah, absolutely. You really have to figure into the picture the individual aspects of the user and what they're going through. And like men have a different road in their weight loss than women do. And women in their 60s are different than women in their 20s. And so, yeah, it all plays into it.
Is there a hormone test? I've been hearing different things. Is there a test that women can take when they go to their doctor and ask, "Can I get my hormones checked?" that will determine if they're what level or where they're at in their perimenopause journey?
I love that question because that is one of the most popular questions that we get from subscribers. So thank
What
you
do
for
I
asking.
do?
Yeah.
They always ask, "Where do I
start?"
Yes.
Where do I
How do
start?
we
How do
find
we know
out?
that we're on perimenopause? So,
Okay,
yeah.
I need water for this.
Yes. We all need water for this. Okay, this is where it gets
Roll up the
good, girls.
sleeves.
All right.
Let's go.
Take
Writing
it
down
to
the
work.
notes.
Yes.
Yeah.
Get your notepad.
I wanted to say this. La verdad es que no sabemos.
No sabemos.
Yeah, we can't really pinpoint the moment that perimenopause starts. We can't with a hormone level, and I'll tell you why. The hormones are all over the place. You would need to measure it pretty much every day, multiple times a day for days to understand these fluctuations that are happening throughout this time. And to be honest with you, it's not that important
Okay.
because you're listening to your body. What is your body telling you? Are you having hot flashes? Are you suddenly anxious? Are you having joint pain? You guys went through all the symptoms. I saw that episode.
That's right.
yeah.
There used to be 30 symptoms of menopause.
Yeah.
Now there's 130 symptoms. It's everything.
Exactly.
Your estrogen receptors are everywhere.
Right.
So it's how you feel. It's
It's
actually
how you feel.
how you feel.
The one thing that they'll say is that when your periods start to get a little wonky,
Okay.
that's really
A
where we would
sign.
say is the beginning of perimenopause. So by the standard medical criteria, when your cycles are more than 7 days variation from what you've been used to, then you can kind of call yourself perimenopause.
Oh, wow.
So that's helpful, but that's not a hormone test.
No.
You know what your hormones are doing. They're going to be all over the place. And then as perimenopause goes on, there's a second stage of it, late perimenopause, where that variability becomes even wider. Now, I'm going to say that the textbook says this, but I believe if your periods show any variation and you're over 40, that's perimenopause.
Yes.
You know, like it doesn't have to be 7 days. The medical community is going to shoot me. Your uterus doesn't read the textbook. It doesn't know. So it's
Right.
these little variations, your cycle getting just gradually shorter. That's perimenopause. And then you have your final menstrual period. And then a year later, you have your birthday, which is called menopause.
Oh, I like how you say it. And that's the difference between perimenopause and menopause. So perimenopause essentially can be longer than when menopause hits, because when menopause hits, that's it. Like you're there
Yeah.
and you know you're there because you don't get your period anymore.
Yeah.
for a year,
You,
at least for a year.
you start spotting at first, and then it comes back, and then you spot again. That's when you know it's getting wonky, and then one day you just don't get it anymore. So it's like a whole year process, and then you're like, okay, it's done.
What if you
completely
get
done.
your period after like 11 months?
Then
Does
you're
that
going
start-
to be evaluated for that bleeding. It's not normal.
Oh.
So then it's like we're getting an ultrasound, we're doing a biopsy, we're trying to figure out what's going on, because it doesn't have to do with your estrogen fluctuations likely. It could be something else. Don't panic, because the most common cause of bleeding after menopause is benign. It's atrophy or thinning of that tissue because it's no longer got estrogen there. So I don't want people to worry if they're bleeding. Just have it evaluated. Check it out.
Can you tell us what the importance of estrogen means for women? Because I think a lot of people don't know. I'm actually reading.
That's true.
I'm actually getting certified in menopause
Yay.
training. So I'm like reading all this and I love it. But I think a lot of women don't know how much they need estrogen,
I don't know.
Oh,
how it affects our bodies.
It's hard to answer that. It's kind of, it informs everything in a woman's body. It really does, which is why menopause is such a huge adjustment, because it's something that has been there this whole time and it's suddenly gone.
Yeah.
But I will say, when you're a little girl, you don't have much estrogen and you feel fine. So it's really that presence of the estrogen brought into your system and then taken away. And there's something about that loss of it that triggers all the problems. But estrogen receptors, as I mentioned, are everywhere. In the brain, in your heart, in your joints, they're all over. So there's really no organ system that it wouldn't be affected by this change. And so that's why in the perimenopause and menopause, all the symptoms that you're feeling really can be potentially attributed to the transition. That being said, I don't want people to dismiss symptoms that really need to be addressed. And so I think where we are in this moment, it's almost like everything's perimenopause. But what I want people to remember is that that's not true. It's not always just perimenopause, but please put it on the list. It was not on the list before. Put it at the top of the list now.
Wow. Well, yeah, it's a new word for me, the word was discovered, I want to say a year ago. I've never even pronounced the word in Spanish or in English. So perimenopause in the last year has been part of our normal vocabulary now. And it's because of this big boom, right? This big, I don't want to say trend, but just this big need to know more about something that was such taboo, especially in our culture.
It's becoming more
Vocalization,
mainstream.
for
mainstream.
sure. Calling it out.
Do you see a
celebrities
difference?
are involved as well. So
that's been a
big
huge
thing.
factor, right?
is?
Celebrities,
Celebrities
speaking
getting
out.
involved and speaking out
Bless
as
their
well.
hearts. Yes.
So that's
Like Halle Berry.
Yes,
Has been a
Halle
big
Berry.
advocate.
Drew Barrymore.
Yeah.
Yes.
And Comadres Unfiltered, thank you very much.
touching on that quite a
But
bit.
yeah, let's talk about that. So a person like you that specializes in this, menopause, perimenopause era of our lives, do you think that we are really milking the moment with all the information that's out there, or is there more stuff coming out that we don't know about? Where are we in that department?
women are under-researched.
Still.
Yeah.
Sadly.
So that's why I say when it comes to perimenopause, we don't know because there have not been all of the trials and all the studies, and women were just recently included in clinical trials. So a lot more is being done. It is being done, but there are a lot of places where we are just, I don't want to say guessing, but we're making educated guesses based on the research that we do have, but it's missing a lot of what is needed.
That is terrible.
Yeah, it is.
So
but
we are
it's-
guinea pigs in many, many ways.
Yeah.
That's the part that I am unsure about because we did touch on the HRT testing, or sorry, your hormone testing, and that it doesn't give any specific conclusion, but it's still good to take, right? And then when you do get the results of your hormone testing, how does that relay into the quantities of HRT? Because that's what I'm just like, okay, so let's say my results come back normal, but I'm feeling still, my hips are hurting, right? Like my joints are hurting. So then how do I know that what I am being prescribed is the right amount of testosterone, estrogen, progesterone? Like, I just don't know.
I think it's the way you
What
feel.
that looks.
That's a great question.
You nailed it.
It's the way you feel.
Okay.
Yeah. You let your body
And
tell
then you test it. If you have a higher dose, then you can reduce it or go up.
You start low,
Okay.
right? Yeah.
You can. You can do either, actually.
okay.
Both are practiced, where you'll start a little higher and come down, or start low and move up. There's no real rule book that says how you're supposed to do it. Every practitioner has a different way that feels comfortable to them. So you can do either, but you don't need to correlate blood tests with what you're taking. When you're feeling better, that's adequate.
Yeah.
That's adequate. And, there's the thinking that maybe the lowest dose possible to get you where you want to be. That's, one way of thinking of it. But even still, you
It
can
didn't
go
work for me.
higher.
And you just go like
so
this.
how does the HRT, is it a cream? Is it a pill? Is it a patch?
Now, what is HRT?
Yes.
Hormone
Okay,
replacement therapy.
comadres.
See,
Yes.
this is one of the most popular questions too. A
Yes.
lot of
Yes.
comadritas that are finally diving into this convo want to know, okay, what is it? I didn't know what HRT meant. I was embarrassed to say, what does it mean? Like I had heard the HRT, but I didn't know what it meant.
Yeah. So we're starting to move away from calling it HRT. We don't think it's really replacement. It's therapy. It's treatment. So we're calling it hormone therapy. We still call it HRT because that's what everybody knows it as. And I don't want to keep people from finding the information they need. But hormone therapy or menopause hormone therapy is kind of where we're at with it. And it consists of predominantly estrogen. Estrogen in the form of a pill, a patch, a ring that goes into the vagina. Or there's also creams, mists, gels that go, we call that transdermal. So anything that goes on the skin is transdermal. And that is probably the safest and best way to get estrogen into your system.
Really?
Vaginally works well as well. So with the estrogen, if you have a uterus, una matriz,
Una matriz. Muy bien, muy bien.
you
I love it.
you want to add a progestogen. And so that is the hormone of pregnancy,
Yes.
right? And it's the hormone of ovulation. So when your progesterone goes up, it means you've ovulated. This happens every month. And then when you're pregnant, you have a ton of it in your system. And it balances the estrogen in the uterus. Okay, so in the uterus, you have cells that are receptive to the estrogen and they will grow. And then the progesterone kind of calms it down and keeps it level and balanced. So
6, 7.
Yeah, 6, 7. Oh my God.
I had to say that. Sorry.
I had to throw that in.
Yeah. So, the two together is typically what you're going to be taking. You can add another form of hormone therapy would be testosterone.
Yeah.
There's no FDA approved form of testosterone for women, but it's also having a moment. A lot of people are starting to add it. It's really only.
I want to add it.
Yeah.
I do want to add it.
What does it
for
do? What does the testosterone do?
It is treatment for hypoactive sexual desire disorder, HSDD. So that is what it's really indicated for in women. So if your libido is tanking and you're just not having desire, if you meet the criteria for that diagnosis, then you are a candidate for testosterone. But you have to take it as a male formulation. So you have to take a tiny amount of it or you get it compounded, which is fine. And they'll give you the right
So they
amount
don't even
with
make it for women right now. They
Wow.
don't compound it for women right now, which is awful because
No.
some women really need it. Now,
Yeah.
I don't need it for that reason. I just want more energy. So a lot of my friends who are taking it, they said I have tremendous energy, more clarity, more focus. So I'm like, I need some of that.
Yeah, I mean,
know.
you can try it. There are people out there that will prescribe it off label and see if it makes you feel better. I think that's fine.
And I heard it's just a little bit of gel in your inner part of the body where it's not really exposing, and you won't get it on anyone else, right?
Right,
So you
exactly.
Kind of hidden.
Keep it off your dog. Right.
Because it does transfer. The gels, the topical.
Yeah, the topical gel.
okay.
Interesting, right? It can transfer to your partner. Like if you guys are having sex and you're naked and you put some gel on there, or he is putting gel. A lot of males also use the gel component.
Yeah.
They get it on you.
Yeah.
That could be really hot.
Maybe that's how you want to get it on your body. Sure.
I'm like,
Are there
don't
any
recommend that.
side effects from any of this? Because I guess that's the other part that I've heard women are just worried, or sometimes they're not able to take HRT for many reasons, medical reasons. And so, I guess the first question is, are there any side effects from maybe going down that road? Because the people are worried.
Possibly
like,
when
you-
is it, or possibly answering, when do you not take HRT?
Exactly.
Right.
Like
When
pretty
do
much
you not?
who are the great candidates and who aren't.
Okay, so in terms of who's a candidate, that's what we're asking. Who's a candidate?
Yeah.
For, okay, so you are basically not a candidate if you have some risk factor that predisposes you to forming blood clots in your legs and lungs, or if you have some sort of history regarding like a heart attack or a stroke or something that means you've had this situation before, then you're not really a great candidate. That's not a ton of women. Most of us are healthy enough to take it. The other consideration is if you've had a history of breast cancer and estrogen receptor positive cancer. So that's another thing. But again, it's not off the table. It's a conversation that you have with your oncologist. And if you're really suffering, it's something that potentially could be added back in certain situations. So, but those are kind of the big ones that take you out of the running.
How
for
about like
taking
liver
estrogen.
disease? If you have liver disease, is that?
Yeah, if you have significant liver disease, because it's the oral
It
forms
goes
go through the liver. But if
liver.
you do the transdermal forms, that's better because it doesn't go through the liver in the same way.
I only have one kidney. Would I be a candidate for HRT?
Yeah,
Okay.
I think so. You could definitely, the transdermal, yeah.
Okay.
Kidney health is.
What about like supplements? Because like you go through, there's different, there's an array of different things that you can maybe start with, or do you? At least that's how I see it. I mean, maybe start with supplements and then go into HRT, or do I just dive into HRT, or how do supplements help?
The most effective treatment is going to be your hormones.
Yeah.
So
I was going to say supplements. No.
Yeah, I wouldn't necessarily start there. If you're young and healthy, I would just go for the hormones. Yeah.
So I'm glad you said that, because that hasn't been my perception. It's like, do I wait, right, until I get older? Because I'm like, well, I feel okay, but like I do feel some stuff, but like, oh, what if I start now? Like, what kind of side effects am I going to have for later on? Like, how long am I going to take
And you're
this
talking
for?
negative side effects, because obviously
Yeah.
there's positive, but are there
Right.
negative side effects?
Yeah, so side effects associated with estrogen would be, think about your period and think if you've ever taken a birth control pill. So it's the same kinds of things.
Okay,
like,
so-
so you could get headachy, or your breast could get tender. Some people have acne.
Can they gain weight? Because when I
little-
was on birth control, I gained weight.
Weight retention, usually that's with the progestogen, because progestogen does has impact in your kidneys mostly, that causes you to retain some water. So yeah,
Okay.
that's a thing. But even with birth control pills, we don't really state that weight gain is a huge side effect. It's a small amount. And to be honest, we're all gaining weight as we get older anyways. So it's really hard to tease out if it's just the natural aging process or the hormones that are doing that.
So I've been on HRT, or better yet, hormone therapy, for a year, exactly a year this month. My question, when I brought this up with my husband, he was all for, like, wow, that's great that that you're advocating for yourself and you actually asked for it without your doctor even offering it. And then I upped my dose and stuff like that. But my question is, it was sparked because he questioned me. how long are you going to be on hormone therapy? Is this like for the rest of your life? And I was like, that is a great question. Like, I don't know. All I know is that now
Your
you're later.
doctor asked you
No,
that?
my husband.
Oh, your husband. Okay.
My husband's like,
Yeah.
are you going to be on it for forever or until when? And I was like, I don't know. I just know that I'm finally feeling great. It took like 6 months to kick in.
Right.
Now I'm like floating. Life is beautiful. I am the happiest wife and the happiest mom.
And he's a happy husband.
And he's a very happy husband because it was affecting my, libido. And now it's like a whole different story. But how long, once we're on it, how long realistically am I going to be on it? I'm 50. So
You're 50?
I'm 50.
No me digas. I don't believe it.
I'm 50. So I went on it when I was 49. Yeah.
Okay. All right.
Which is good.
Which is
Yeah.
good. I mean, going back to, what you were mentioning, I don't know how I navigated without anything, but I did. But, at 49, I was like, I need something, right? And
you probably should know. At 44.
46.
49, 50
50.
now.
Mid 50s. So I'm the oldest here.
I'm 49, so.
Somos el club. Yay.
Yes.
So
I was the first one to actually
Yes.
Go through the
talk about
journey.
this with the
Yes.
girls.
Yeah.
They didn't really know about it.
Yeah.
So I said, I'm on this. I have to try this. Because like I said, I started getting all the symptoms in my mid 40s, not knowing what it was. So I'm just so happy that I got educated by some holistic doctors that guided me, because my regular Western doctors never even talked about it. They said, well, welcome to your late 40s.
Late 40s.
And it gets worse as you get older. It's part of life. And I thought, this cannot be it. There has to be another way.
Yeah.
So look, I discovered it. I talked to you about it. Then you asked your doctor about it.
Which she did say,
Yes.
es parte de la vida.
It's
You're a
part of
woman.
life,
It's you
right?
just
It's
navigate
normal.
through it. But anyways, I was able to tell her my concerns and, push for the HRT or hormone therapy. But my
how long
question
do you
is,
take it?
how
Yes.
long is it
So
going to last
there's-
in my body?
Yeah, there's no right or wrong answer to that question. You can take it for the rest of your life. You can trial coming off of it in 5 years.
Okay. In 5 years and see.
Taper off of it and see what happens if the hot flashes or whatever your symptoms come back. You go right back on it. You
Simple
can
as
take
that.
it for as long, and they're getting some more data around how, the length of time that you can take it, and finding that it is safe to take longer. So especially if you are on it this whole time, what the study showed is the ones that started it in their 60s without ever having been on it, those were the ones that had more of the adverse events. But the patients that kind of are always on it, you can stay on it. It's totally fine. It's really up to you and your comfort level and how you feel, and if you want to try coming off of it. But I would stay on it for a while, 5 years.
Yeah.
And see how you do. We're finding that there's cardiac benefits to being on it. So we don't have great research around this yet. There were a couple trials that show that the signs of cardiovascular disease seem to be diminished when you're on hormone therapy. And I think with
That's a
more
big plus.
time, I think we're going to find the benefits of being on it way outweigh the risks of being on it, which are small, to be clear. And I think as we get more of that information, more people will proactively go on it for preventive reasons. Right now, it is not indicated for any of those reasons, but a lot of the studies are showing that it is cardioprotective. And we know that because women experience heart disease. Heart disease is the number one killer of women. But we have our heart attacks later. We have our cardiac disease later. And you know why that is? It's because estrogen has been protecting us this whole time.
Wow.
Wow,
Yeah.
that's interesting.
Yeah.
And talking about estrogen, I do want to touch on bone density and the protection that estrogen does give you. So the earlier you start the estrogen, taking estrogen, I want to know the benefits of that.
Yeah. So the earlier you take it, again, it has to do with this window of when it's best to take. And we think that window is within the first 10 years of menopause and before the age of 60. So when you get in there, that's really when we see the most benefit. I want to add that people who have their menopause early, in their 30s, either because their ovaries have failed. We call that primary ovarian insufficiency. So that's a diagnosis that only about 1% of people will get. It's not super common, but as a gynecologist, it's something I've seen and have to keep in mind when I have patients that are not getting periods in their 30s. Or if you have early menopause before the age of 45, the thinking is to just put patients on hormone therapy, regardless, to protect their bones. What you're saying exactly, because estrogen is the main factor in our bone health as women. And we suffer osteoporosis more than men do. And hip fractures have horrific consequences. Up to a quarter of women will pass within the year of having a hip fracture. So
that alone,
that alone is very motivating. And it is actually FDA approved for prevention of osteoporosis, not treatment, but to prevent it. So if you're a high risk person, your mom had osteoporosis, hip fracture, it's a conversation to have with your doctor as well.
My mother did have osteoporosis. She has it really, really bad. She's had it for many years. She never took any type of HRT at all. She didn't know about it. And now she's suffering with very, very weak bones.
Yes.
Is she on treatment? Because there are many really effective treatments.
Yes, she is on treatment now, but it's a little too late.
Yeah.
It's a little too late for her. So she's 74.
74. Talking about age, the patients that you've seen, who's the youngest patient with perimenopause?
They say in your 30s it can happen, but I think it's more rare. And I know that in our menopause moment, we're pushing for earlier. Oh yeah, this is happening to you and you're 35. It's perimenopause. Yeah. I want to pull back on that a little bit. Okay. I think the symptoms really start to come out in the 40s because they're going to happen, it's variable, but years before you truly go through menopause. So it is very possible that your symptoms showing up in your early 40s are perimenopause. But I'm hesitant to label everything that happens in your 30s as potentially due to perimenopause because I think that opens a whole other can of worms. And then we ignore things that really need to be.
So there's a myth. True. Apparently, like the later you start your period, the later your menopause is going to kick in, one. And I've also heard that you got to ask your mom when did her menopause hit because that's going to be you. So I was a very late bloomer, 15, my period. And look at where I'm at now. My mother was a early bloomer and her menopause kicked in her 50s. So it's like, I'm confused. We're all confused.
Yeah, it does have something to do with genetics. So asking when mama got hers is going to help you predict when yours comes. As far as I looked it up the other day and I can't remember what the answer was, and I should know I should know this, but I can't remember when the significance of the earlier period has to do, if that is going to shorten your interval of having periods. But I will say that we ovulate or we lose an egg about 400 times in our life. And that's really the distinguishing factor of when we're going to go through menopause. It's when you run out of eggs. It sounds like you need to go to Trader Joe's.
In our case, Costco.
Well, we are. The Trader Joe's is a hormone therapy.
Yes. And damn, those eggs are expensive.
Yes.
Not at Costco. Not at Costco.
They're priceless, really.
They're hormone therapy. I do want to touch on that because we talked about talking to our moms and talking to our family and our friends. And I think, especially growing up Latinas, this is not something that we definitely spoke about. And I want to say after our episode that we recorded last year, after that is when I asked my mom when she went through her menopause.
For the first time.
For the very first time.
Yeah.
Not only that, but after that, I was in Mexico and I have cousins who are even older than I am. And for the very first time, I brought it up at the table and I'm like, wait a minute, what are you guys going through? And they started to be really shy, but then they opened up. And I feel like so many women have been so reserved and shy about talking about this topic. So like, I think that is something that maybe we see more of.
You know what, Janet? Because when you talk about menopause, it means that you're freaking old. You're old. So nobody it's so taboo. Nobody wants to talk about menopause because that puts you in that category of now I'm freaking old.
Yes.
Right?
It's a message we're sending to society and also to our men. Because men, the more age, it's like the more masculine, the more manly. And for women, especially in Latino culture, it's like, oh, you don't even want to bring it up to your husband. Yeah. Because that means that that means you can no longer bear a child. Your machine doesn't function like it used to. So what's the purpose of being a woman? That was the upbringing of our great grandmas and our grandmas and even our moms, really. Because you're right. My mom and I, my sisters, we never had that discussion. I just remember my mom really crying a lot. She was already at my house living, helping me with Camila, raising her. And she would cry a lot. I remember once, I'll never forget, one day, I don't know what she did in the kitchen. And I said, ay, ama, es que como se le ocurre. And she started to bawl. And I felt like a terrible daughter. I was like, oh. And then later on, she admitted I was going through the thick of it and I didn't even know it.
Yeah.
That's how emotional and sensitive she was, but she had no idea what was happening with her emotional state. And I feel so guilty.
But that was the narrative. And I feel like what we just talked about is like taking our narrative back. And now it's just like, no, I am not going to be put out to pasture.
Yeah.
Like I am taking control over my
Yes,
life.
that's
And
right.
I am here.
Thank
and
you.
I am here to show up and to stay. And
I'm
to
still valuable.
I am very valuable.
And
even more
hot.
than, yeah.
Hello.
Yes,
Active,
I think
sexy.
I definitely think like it's brought more empowerment to women. Like, not having their period is kind of empowering. Like, oh, I don't have to deal with that anymore.
And save money.
Yes, and I think now this whole talk of like, also exercising more and exploring
Building
your
muscle.
body, and now I guess again we know more women who are single now. It's like it's kind of empowering to go through it and
It is.
be strong and educated on it. The hormone replacements and all that. I think that it says a lot for itself.
Have you noticed that women come into your office with these kinds of feelings about just not wanting to talk about it, or maybe not wanting to accept it, or maybe you're a little bit more empowered? I don't know.
Or they're
What is it
clueless.
like
There's
now?
two types.
Yeah.
I think that there is this attitude of shame and fear around it that we need to rewrite. One of the leading theories around why menopause even exists is that it took women out of the reproductive circle so that
Right.
they could find value in every other way that a woman shows up in the world.
Oh, that sounds beautiful.
And it's the community that thrives when they take care of their woman who's aging, the grandmothers. When we take care of our tias, that's when we as a whole society are going to be healthier. And we're here for a reason. We add so much value to our cultures.
Amen to that.
Oh wow,
Yes.
that's beautiful.
Beautiful.
That's a poetic way of seeing it, and like from that perspective, you're right. You know what? Your childbearing days are over. Your period days are over. Enjoy life and explore other facets of who you are.
There's so much
Right.
more to life than just raising a child. And I know there's so much about raising a child that's beautiful and wonderful, but there is so much more that we have to experience that we're
Yeah.
here to do in the world. We have a message to give to everyone. And so it's great that we're here talking about it because we're going to be doing that.
We should have parties of when our periods are over.
I was
and
just
our-
going to
you
say
know,
the
like,
1 year
we
birthday.
should.
I love that.
We should celebrate
We
that
should.
too.
The
You know.
full-blown menopause.
I remember you were talking about femininity,
Yes.
and I would also invite you to accept that feminine shows up for you at every life stage. It's always going to be there.
Yeah.
It's part of who you are. You don't need your estrogen to show up as a feminine entity.
Yeah.
And it's funny, in the 60s or 70s, there was this book where they were promoting hormone therapy. The name of the book was Feminine Forever. So it was trying to talk about femininity in this negative way, that like you want to be feminine because it keeps your man happy. But the truth is, being feminine is so fun and beautiful and can carry on, continue forever.
Yeah,
I love that.
I like that.
Yeah.
Girls, you guys want to touch pellets?
Yes.
Oh,
Yeah.
I
What are your thoughts on pellets?
I just
Yeah.
brought it up. When I was exploring the whole hormone therapy, I brought up the word pellet, and my doctor said, "No, not gonna happen." That's all I know. But I know that our comadritas have asked about pellets. So let's talk about. Is there a controversy with pellets?
I mean, I have friends who are doing the pellets.
So
Yes.
Tell us
Is it
what's going
pellets
on.
or pallets?
Yeah, I don't even know how to say it.
Palette. Okay.
Palette.
Like
Palette.
palette.
Yeah, they're
P-A-L-E-T-T-E.
Thank
Okay.
you. Thank you.
Okay.
yeah. So Dr. Karen is going to tell the comadres and the community not to use the pellets because once they're in, you have no control over them versus your hormone patch, your cream, your pill. If there's an issue, you stop it. The pellet is buried in your skin. You can't get it out. So I don't recommend it. I know plenty of people love them. If you want to get them, that's fine. Just I personally don't advocate for them. I had a patient who showed up with a pellet, and her estrogen, I checked her hormone level, was 3 times the highest estrogen I'd ever seen. And I
Wow.
didn't know what to do with her because estrogen in those amounts can cause cancer.
Oh, my
so you
gosh.
have to balance it with the progesterone. But I mean, I've never seen a hormone level that high, so I didn't really know what to do with her. So we just kind of had to watch her and make sure that it wore off out of her system. And
my
I just
God.
thought that was not a great way to
Wow.
go.
And can you explain where pellets are, or the pellet is put in, just so people can get an idea?
I think they go in the
Buttocks?
in the
the upper part of the
Yes.
the buttocks.
So,
Yeah.
Yeah, I think
I've
so.
never
Right, I
placed
heard.
them.
But it's
again,
like,
not
it's,
being a
it's
fan,
surgical, I think, right? I
It's
think
a
they-
little device that they
that
use
they-
like a
that they
little
use.
gun, and they
Oh,
They
wow.
shoot them in there.
So it's like a little pill?
Yeah, it's like a little pill that
Inserted. It's
a little
dissolves
pellet.
over time. About 3 months they're active for.
Oh.
Yeah, I think have control over what you're doing to treat yourself, and the pellets are kind of like shooting in the dark a little bit. So
That's
right.
Not a
I
fan.
believe that.
Is hormone replacement therapy or hormone therapy and pellets, are they covered by insurance now or?
Not the pellets, but your standard estradiol,
Yes.
your patch and your pill are going to be covered with your bioidentical progesterone.
Yes. Thank God for insurance covering that. But maybe you can clear this up for us. I had heard that there is some sort of proposal, hopefully in Congress or Supreme Court or, up in the government spheres of trying to make this available to women in general free because we don't control this that happens to our bodies. It's just that's the way God made us.
I
so
believe we
why do
deserve
we
it.
have to
Yeah.
pay
Because
for feminine products, the pink tax,
Yes.
right? But why do we have to pay for HRT, or I'm trying to say hormone therapy.
I know exactly.
I'm trying to get it used to it. Where we don't ask for it. I mean, it's not like it's a luxury; it's a necessity.
Yeah, I completely agree. Should be covered for everybody. And I think with more time, we're getting there. Like just recently, the FDA, they'd had, I don't know if you heard
The
this.
black box?
Yeah.
Such great news.
That was
Yeah,
removed?
so there was this warning on vaginal estrogen
Right.
that was completely irrelevant. That was placed on there because of this study. I don't know if you've all gotten into this, the WHI. You do.
Yes, I know.
A little estudiante. They decided that estrogen was just super dangerous. And so this black box warning went on everything when we know for vaginal estrogen. So can we talk about our vaginas for a second?
Claro
Yeah.
que
The
sí.
JJs.
Yes.
The JJ. As we get older, the estrogen loss causes that tissue down below to get thinner and less healthy, let's say. So we have a product called topical local vaginal estrogen, estradiol, that you can use throughout the week to keep that tissue healthier. And it helps with your sex life. It helps prevent urinary tract infections. It has a lot of utility. So prior to this, I think it was November 10th, there was a warning that said it was really dangerous, causes breast cancer, causes heart attacks. None of that is true. So I encourage women to have at least that conversation as they're noticing the changes. Get a mirror.
Yeah.
Check down there. See what's going on. Get familiar with your body so that you can see the changes as they're happening and then voice this to your doctor and get this on board and use that for the rest of your life. I'm a big advocate for that.
I
And
did
no more
hear
black box
about
warning.
Yeah, I heard about
I heard
that
about
too.
that, especially going into the later part of our lives, the 70s and the 80s, because there's so many women that get UTIs and then that turns into sepsis and,
Exactly.
the older they get. And so this is one way that can help that we never knew before.
Yeah.
So it's like, you talk to your moms, talk to your grandmas and,
That's right.
get them on this.
Yeah.
It just helps them out.
Yeah.
So much to learn.
So much. And you know what?
So much.
So much of our followers have so many questions to ask, right?
One of the questions
yeah.
is that, okay, I love that we already talked a lot about hormone therapy, but still, there might be comadritas that are skeptical, right? And that's okay. It's fair enough. So let's say they don't want to go on hormone therapy. Is there another way for them to navigate, these symptoms, anxiety, hot flashes, blah, blah, through exercise or nutrition alone or something else that's not hormone therapy?
I advocate for all those things. I think nutrition is really important. When we're looking at diets that are particularly helpful in the midlife, Mediterranean diets
I love that one.
are kind of the best. That has the most
Yes.
research that backs its use.
Yes.
Exercise 100%. For all the reasons, I completely endorse that. There are treatments that are for vasomotor symptoms predominantly. So vasomotor symptoms are the hot flashes and the night sweats.
Okay.
I've had night sweats, not anymore. Hot flashes, not yet, thank God.
Yeah. So some people only get the night sweats. So everybody's a little bit different. There's so much
I've never had night
biodiversity.
sweats ever.
Sorry, I've had night sweats since I was in my 20s.
Yeah.
Yeah. And just on random, I would say random months. And I usually affiliate them, closer to my period dates.
Same.
And I've been having them since I was in my 20s. And I remember my gynecologist said, well, I can put you on hormones, but then you're going to have other side effects. So he's like, you decide, what you want to do. And I was just like,
Give and
it's not,
take.
they're not every night. They're just, again, I
Random.
associate them with my period. I mean, I had them sometimes I have them for a whole month. And then knock on wood, I haven't had any in 3 months.
Well, not that I'm pushing for hormone therapy, but ever since I
Yes.
went on the patch, night sweat's gone, and it's a beautiful thing to wake up with no wet hair stuck to my back.
That's right.
And cold, wet sheets.
Cold sweat is the worst.
Yes.
Because it's a contradiction, right? You either get the hot flashes or the cold night sweats. It's like, and men don't go through this.
No.
Well, maybe they do, but not at this level.
Can I say they don't go through it because they can't handle it?
Probably. Yes, you're right.
point.
You're right. They can't have a baby because they can't push it out.
We love our men. Let's not dog our men. But
I always say that God gave us this life because He knows we can handle it.
Yes.
We don't have to. And that's the other
Janet,
thing.
we don't have to.
You know, that's the one thing that I think opened my eyes is that we always saw this as a sentence, right? And I'm just like, I don't want to suffer. Like, and there are women that are speaking out more, and I'm just like, forget that. Like, when I do get to that phase that I'm getting even more of these symptoms, I want to do something about it, you know? And so I love that you're helping us learn a little bit more about this journey. You know, there are other things that also, that are symptoms that we talked about, just like the wellness and working out. And the one thing that I've heard is that people are doing like microdosing GLP-1s.
Yes.
What is that all about?
Exactly.
And how does that help perimenopause and menopause?
So GLP-1s are the medications that are super popular right now. They're predominantly injections that you're going to take once a week, and they work in a variety of different ways to sort of suppress your appetite and help with weight loss. When you take them in small doses, we see a lot of the benefits that you get on the fuller doses. So right now we're in this time where we're seeing kind of like what's the smallest dose that we can take and still have a lot of the benefits that come with taking a GLP-1. Right. And GLP-1s, when taken together with hormone therapy, actually are additive and seem to make the weight loss even more effective and more meaningful. So they kind of work in tandem. And I do think that because menopause is sort of an inflammatory time as estrogen goes away, GLP-1s are also anti-inflammatory. So just taking a small dose of them can be helpful to sort of help you manage weight and appetite, not necessarily hot flashes. So I wouldn't be taking microdose to get your hot flashes to go away. I'm still going to advocate for the hormones. But for a lot of the other sort of inflammatory things that we see, these smaller doses of the GLP-1s can be very helpful. And we're learning more.
So this is good for like the women who are, one of their biggest symptoms is waking, like sudden waking. They're eating well, they're exercising, but
The
they're
big
not.
belly.
Yeah, they're not
The
losing
visceral
weight.
fat.
Yes.
Which we should definitely do an episode on just GLP-1s, by the way.
Yes.
Because that's also like a very new thing for many of us. I'm still learning.
We're curious.
A lot of questions.
Yeah.
Have me back on because
We will
Yeah,
bring
right.
back on
Yes,
just to
absolutely.
literally focus on GLP-1s,
Yeah.
right?
Absolutely. Yeah,
But
we
we
can
have
talk
so
more
many
about
questions from our subscribers, comadritas, and we promised them that we would answer some of their questions. So do you guys have your questions ready from the comadritas that you think are valuable and that
That we haven't answered
that we haven't
already?
answered? Yeah, because many of your questions, comadritas, we have, well, not we, she has answered.
Oh yeah, I'm looking at my
Yes.
list and she answered
It's like check,
most
check,
of
check.
them.
Yes.
So we're on the right
Yeah.
track. But I have a situation with one of our subscribers.
Oh.
Can I read it?
Yeah.
Yes.
Go for it.
So we're not going to mention your name, but I know who you are. It says, RG, I had a procedure done after my second child called Essure. I'm almost 50, and in the past 2 years, I have suffered of itching around the vagina area. It's very uncomfortable. I feel that I will scratch myself and rip my skin. Is that normal? I have gone to the doctor about this issue, and I was prescribed progesterone in a vaginal ointment along with the steroid cream. I don't know what to do. Ya no sé qué hacer. It sure is a birth control procedure where a spring was placed around my fallopian tubes. I had the procedure done 12 years ago. She was very, thank you for it's a very clear message. I didn't even know what a sure was. So thank you. That sounds painful for her.
Yeah, there's a lot there. Do we know how old this woman
No.
is? Okay.
Oh, I'm almost 50.
Okay. Okay.
So she's our age.
Yeah.
Yeah.
Okay. Essure is an episode on its own, but I'll just say I placed those devices. They're done hysteroscopically. So you go into the uterus and you put these little coils inside the fallopian tubes. Las trampas. Is that what you're saying?
Oh, las trompas.
Trompas. Right. And that blocks them essentially. And then it's a sterilization procedure. So those were done for not that long. And then the FDA shut that down.
Is that like tying the tubes?
Yes, it sounds like it, right?
Yes.
Get my tubes
It's
tied,
like
they
the equivalent
say?
of, getting
Like the
your
modern
tubes tied.
version.
Yeah.
Yeah. So we did lots of these, but women were complaining of pelvic pain and hair loss and like a million different things. It could have been perimenopause, but they shut it down. So we don't do them anymore. Some women had them removed. 12 years out, I'm not blaming anything on that, though. I think she's okay with the Essure. If she's having pelvic pain, she can see her doctor. But in terms of the complaints on the vulva,
Yes.
she needs to see her gynecologist because they need to assess and do a biopsy and make sure that there's nothing else going on. And then typically the treatment she's on is good. The steroids, that's usually first line for these kinds of things that happen once we've confirmed what it is with the biopsy. And then I would add the estrogen cream 100% to that patient. But I would not necessarily say the Essure had anything to do with the symptoms she's having because what she's experiencing is super common.
There it is.
Super
Essure. That's a new word for me. Now I know. Gracias.
Yeah.
Hopefully that gives you some clarity, amiguita. And I say amiguita because she's one of our, I remember, I recognize her name from one of our Comadrita subscribers on our YouTube.
That's great.
So I was like, oh, yeah, we already know like the names of our subscribers. So thank you so much. Yes.
And talking about itchy down there,
Yeah.
another follower was asking that her vajayjay is quite dry, that it feels like sandpaper. She said it's very uncomfortable. She says, what can I do?
So this is what we're talking about. It's called genitourinary syndrome of menopause. Formerly, we called it vulvovaginal atrophy. And it's basically the depletion of the estrogen's effect on that tissue there. So the treatment is the estrogen. So you would start with, you take it every day for 2 weeks, and then you cut down to 2 or 3 times a week. And it works wonders. And I would encourage.
And you just apply it.
You just apply it.
It's
Yeah.
just
They give you
a
a
cream.
little plunger and you can kind of put it up there. If you've ever done like a yeast infection treatment, it's like that kind of situation.
Oh, wait a minute. It goes that deep? in there?
Up in
Oh,
there,
I thought it was just on the outer.
No,
Oh,
you can put it up there. The other thing to do is vaginal moisturizers. So there's lots of products out there, hyaluronic acid, and Bonafide has a product. And these are all
over the counter?
Yeah, over the counter, different
Okay.
things that you can do. And you can start with that. But because the estrogen is so intimately related with how that tissue is, the health of that tissue, I think estrogen ultimately ends up where we go. But you can couple it with moisturizers and do that as well. And then there's some non-hormonal treatments that you can use for that as well if you're not a candidate for estrogen. There's an oral pill, and then there's a something called Intrarosa, which is DHEA that goes in the vagina, and that helps. It converts to hormones. So yeah.
What you're touching on right now is actually the next question that we have. And I would love for you to elaborate on those. So the question is, any natural remedies for women who are breast cancer survivors? I am one, and Anna's wild yam cream. And I use Anna's wild yam cream, but still some hot flashes here and there. And I'm 46 and in perimenopause. So you did mention these two. Are there any other natural remedies that you can use that are not hormone therapy?
Not natural remedies, but there are non-hormonal treatments for menopausal symptoms. So there's one that's kind of on newish. The brand name's Veoza. And then there was one that's similar to it that works a little differently that was just FDA approved. Alinzatant. I can't even pronounce it, but it's similar, and it's a pill, and it works for vasomotor symptoms. Very effective, helps with sleep. There's also there's a whole list of things like antidepressants at lower doses can help, gabapentin, clonidine, oxybutynin. So there's a whole formulary of non-hormonal treatments that you can talk to your doctor about and try any and all of them. And they're all effective in clinical trials to reduce vasomotor symptoms.
I've heard magnesium, ashwagandha. I've heard all of these types of supplements. How does that help?
And I'm glad you bring it up because that's one of the most popular questions. Sleep is an issue. Insomnia. I went through it too. I've shared that I use magnesium, but is there something else?
I remember you said that.
Yeah, it's been wonderful. And I'm on it every night. You know, after dinner, I'm like my 2 little pills of magnesium so that 2-3 hours later, I'm relaxed and
it works.
sleep like a baby.
Yeah,
I love it.
I take it too. So when it comes to sleep, it's multifactorial. And so you want to look at the whole, like there are sleep medicine specialists out there that do fellowships just to learn about how to improve our sleep. But number one, if you're in perimenopause or menopause and you're having your hot flashes, you want to treat the hot flashes. If that's what's interrupting your sleep, you want to go there. But then you also want to think of other things that can show up as we age. Restless leg syndrome becomes more common. Do we know what that is?
No, what is that?
It's like this relentless desire to like move, and it can show up in your arms or in your trunk, but typically it's in the legs, and it's like you're constantly having to move. And
Like
so
jittery?
yeah, it's like just a sensation.
Uncomfortable.
Yeah, like a sensation like I have to move my legs.
Yeah.
And that shows up more. It's thought to be related to estrogen fluctuations. So it happens a lot in pregnancy, can show up in menopause and perimenopause. So that's something to think of. Sleep apnea becomes more common as we get older. Hormones, if you can believe this, influence your airways. So as your estrogen and progesterone go away, sleep apnea becomes more common. You want to be evaluated for that. And then there's, you can do supplements. Magnesium, I'm okay with. Ashwagandha, I'm okay with. But when it comes to like melatonin or some of these, melatonin works, but I just wouldn't take anything that you have to be on, with the exception of magnesium, long term.
Yes.
Because sleep should really be dealt with, not in a kind of like Band-Aid sort of way, but in a root cause sort of way.
Which is kind of like functional medicine, right? That's that's how the way they see it.
Yeah. So diagnose your medical issue, take your hormones if that's the problem. And then the other things you do around sleep have to do with what we call sleep hygiene, which is the whole thing about like put your phone down half hour before you go. Make sure your environment's cool. Make sure you're comfortable. Keep it really dark. Limit light exposure. And then the most effective thing for insomnia is therapy. Cognitive behavioral therapy with an I at the end. So CBTI for insomnia. It's sort of the gold standard. 4 to 8 sessions you can do with a trained specialist. They'll sit with you and kind of train you how to talk to yourself, because a lot of insomnia has to do with this thought of like, oh my God, if I don't sleep, I'm not going to function. So it's undoing that mindset and knowing I can get through my day. I'll be fine. And it's just one night. This doesn't have to be the rest of my life. So you kind of learn how to talk to yourself. Yeah.
Just quieting the mind a little bit.
Yeah.
Learning how to do that.
And speaking of therapy, also pelvic floor therapy. Is that important right now during menopause, perimenopause?
It absolutely can be. And there are so many things that are alleviated by pelvic floor dysfunction. So yeah. And again, the list is endless, but control of the bladder, sexual function, pelvic pain, all of these things are influenced by the musculature in the pelvis. And if you go to a therapist and get those worked on, yes.
Is it also connected to the lack of estrogen?
Yes, the estrogen definitely supports the tissue down there. So we see more of all of these complaints.
Wow. So estrogen is absolutely
everywhere.
important.
This question, I've seen it everywhere with family members, amigas.
Yes.
Hair loss. Our hair is our crown.
Yes.
Our hair is everything.
Yes.
So we have comadritas literally crying. I am crying as I write
I'm
this.
crying also.
Yes.
How do I control?
I'm on that question too.
How do I control hair loss? I don't even want to shower because every time I shower,
It's scary.
it just comes like nothing. This is a real dramatic, painful thing to see.
It is.
Yes.
So hair loss starts in your 30s. So it's something that's been ongoing, but we kind of don't notice it because we wear our hair certain ways, but it just really becomes more pronounced as we go into the perimenopause. It is a very big complaint of women going through perimenopause. The most common thing we'll see is what we call female pattern hair loss. And it's kind of like at the top of the head that it starts to go away.
Is that like alopecia?
It's like an alopecia, yeah. And so for these, there's a topical treatment that you can do, minoxidil. It's, I think, the only FDA-approved treatment for hair loss. But I would see your provider and talk through some of the treatments that are available. There's like over-the-counter, like caffeine shampoos and these kinds of things that actually have some evidence. And antifungal shampoos, zinc shampoos. There's all kinds of things that have some good data behind them in terms of helping with hair loss. But it's incredibly common. And again, hair is like... It's so connected with how we relate to ourselves, and its loss just feels really, really.
I'm just
painful.
wondering if
Sad.
it's like it's something to do with the inside of your health, or is it like your scalp?
So what happens really is that hormone. Again, we're blaming the hormones again.
Yes.
So it's kind of a shift in the ratio between estrogen and androgens. So it is an androgenetic form of alopecia or form of hair loss. And that disruption of the balance because estrogen's dropping, testosterone relatively is going up. And as we know, men go bald because the testosterone has an impact on their hair. And the same thing will happen as our hormone shifts. That's why we lose the hair. It's not the only reason. It's also environmental. It's a large part genetic. So we're not going to blame just one thing on it, but that kind of gives you an idea of like what's going on. And I would definitely advocate to get treatment and get a workup. Have your iron checked, have your vitamin levels checked, make sure that you're getting good, adequate nutrition because your hair also responds a lot to your nutrition. And then the other thing I'll add is there's a situation condition, telogen effluvium.
Never heard
it's
of
a
that.
mouthful. Have we heard of that?
No.
That is basically a stressor in your life. You have a delayed loss of hair. I don't know if you've noticed that when you were pregnant.
I heard when you lose your hair, look what you're doing. Was it 3 months or 6 months before?
Yes. One of my coworkers was like, I'm losing all this hair. And I was like, well, don't you remember your cousin died in July? And I think that you were under a ton of stress and it's showing up now.
Wow. That explains a lot.
Yeah. So that's something also to keep in mind with hair loss.
Right now, you mentioned like check your iron levels and stuff like that, which is also related to a question that I think is very valuable because I've had this concern as well. She wants to go to an endocrinologist, and I don't know if our insurance covers visits to an endocrinologist. Why don't we have access to that? And how is visiting an endocrinologist going to help us navigate perimenopause and menopause?
Endocrinologists are great. And you should, if you have general insurance, be able to get a referral if it's indicated to an endocrinologist. Okay. But they're great because they really kind of know all the things. So they can treat menopause, they can treat weight, they could treat potentially hair loss. There's so many different places that they have their fingers in: thyroid conditions, diabetes.
Oh, wow.
So much is related to our hormones, and endocrinologists are really kind of the gurus of our hormones.
Yeah, because I know that we've had the discussion that when we get our blood work done and then we go to our annual physical, the doctor just kind of like, oh, you're good. Cholesterol levels, sugar, glucose. Happy start, go, bye. And it's like, I want to know more. Yeah. But in order to know more, we have to go to an endocrinologist who really is going to get in the nitty gritty of what are we missing.
Well, especially when they're telling you that your labs look great, but you feel like shit.
You come out.
That's the worst.
Oh, you walk out and you still don't know how to explain it to your husband. Like, it says, I have a happy star, so I guess I'm good. But no, we want to know exactly what is it that's still not making us feel good.
Right. And that's why I'm saying the labs are so important for so many things, but they don't tell the whole story. We're not our labs. We're how we feel. Exactly. And so sometimes that's what you have to look at more than anything else.
It's very frustrating.
Very frustrating.
Yeah, because you know your body better than anyone else. And I think that was one of the things that came up with symptoms. It's like, well, I started to feel this. Well, it's prolonged, right? It's like something that came out of nowhere, something that you hadn't experienced before. And so when you know that your body's not feeling well, that's when, maybe a test that tells you everything's okay, you're like, no, everything's not okay. Like something's going on.
And you
so
have to dig deeper.
I love that. Yeah. It's just advocating for yourself, knowing your body better than anyone else, and then telling them like, no, something's wrong. Like, let's keep looking.
And hopefully finding a doctor that's understanding about that and wants to work with you.
Right.
That's important.
Exactly.
Very important.
Because then you have the
and I guess if you're feeling great, you don't need to do all these tests just yet, hold off on them. But if you are feeling not great, then maybe that's the time for you to look into the endocrinologist.
Yeah. And your primary doctor can do a basic workup. Thyroid would be the one thing that I would check in a situation like that where you're kind of feeling not completely there, not completely well.
There's one thing that has come up over and over again, and I'm sure you have seen it scrolling on your Instagram, and it's getting more prevalent and more prevalent. It's called NAD.
Oh, yeah.
Oh, yes.
What is NAD?
NAD is basically like an energy precursor. It's implicated in metabolism at the cellular level. So it's thought to be related to energy. And if you add it, it's supposed to sort of rev you up and give you a little bit more energy. And again, because we're so...
Yes, more energy.
Yeah, they do infusions and you can take it orally and these kinds of things. And again, I don't think we have a ton of data on whether or not it's a magic bullet, but I think it's safe enough to experiment and explore and understand where you don't have evidence. You're taking a little bit of a risk, but it's your body. And if you want to go and try something like that out, do it. I was at a longevity conference and they were giving injections and I'm like, fine, I'll take it. I didn't feel any better, but
and they're not cheap either.
And that's kind of the kicker too, is a lot of it
expensive.
is to get money. So
they're now doing supplement that you can take, but then I hear that the only way that it can actually be beneficial is through injections. So I'm just, there's just a lot of misinformation out there.
Yeah, and I think we're
about
still
this.
learning, but I think you're right. Like the bioavailability we say is better if it's injected. And so if it goes through your GI tract, then it's not really going to be absorbed as well. So yeah, that's the reason.
I have a question. I still haven't gotten to this chapter, I guess. What are bioidentical hormones? Is that what it is? Yeah. But and then there's another one, bioidentical and synthetic, or okay.
Yeah.
Okay.
Yes.
Can you tell me the difference?
Yes,
Please.
I can. So the bioidentical hormones are really what's being prescribed today. You're not going to probably find a provider who is going to give you synthetic hormones, which is what was studied in the WHI. So the WHI Women's Health Initiative was a study that was started. Is it okay if I get into this?
Yes,
Yeah.
of course.
In the late 90s to look at a few different outcomes, and was shut down early because they said, oh, all these women are having heart attacks and getting blood clots and getting breast cancer. We're going to shut this down. They were studying the synthetic hormones. So the conjugated equine estrogen, which is what's taken from urine of a pregnant horse. So it's a whole variety of different estrogens that they formulate into hormone therapy. And then a progestin, which is a synthetic progesterone, medroxyprogesterone acetate, and put those together. And then you got the results of the WHI, which didn't look that favorable, shut the study down, took everyone off their hormones. It was a huge disaster. Now we are using bioidentical hormones or body identical hormones. So these are hormones that basically look the same structurally as the hormones our bodies are producing. So it's thought to be safer. It's thought to be less linked to cancers and all the bad outcomes that were happening with the other hormones. So as a practitioner, I'm not really going to even prescribe the synthetic.
Okay.
I'm only going to prescribe bioidentical. In estrogen, it's called estradiol.
Yes.
So that is one of the 4 estrogens that are produced in the body. And it's the predominant, strongest estrogen. That's kind of the estrogen we're talking about. Estradiol or 17-beta estradiol. And then as far as the progesterone or micronized progesterone is the bioidentical for progesterone. So if it's a progestin, that means it's synthetic. So that's the ones that are in birth control pills are progestins.
Okay. And since we're on that topic, this question I think is connected to that. And I feel like it's important to answer this. If you don't have any signs, but you're close to 50, can you and should still take hormone therapy? What are the benefits for taking? Well, we talked about the benefits, but if you're not feeling any signs, but I guess it's following the number 50, should she just get started?
Yeah, the answer is no. It's FDA approved for treatment of vasomotor symptoms for people who've lost their estrogen earlier in life, for the genitourinary syndrome of menopause or GSM, and for prevention of osteoporosis. So if she doesn't meet those criteria, she doesn't really need to take it. But this is a conversation that people are having with their doctors now, and I would be open to that conversation if a patient really, really wanted to be on it. I don't think providers necessarily need to shut them down, but I think mainstream medicine would say no. You don't need to take it. We do not have evidence that it is cardioprotective to the extent that we recommend it for primary prevention of bad cardiac outcomes.
So it shouldn't be for prevention. It should be when you're in it.
That's a good question.
But here's another thing. Like, because my mother has osteoporosis.
Yes.
So even if I were feeling fabulous and I'm hitting my 50s, right? I had a DEXA scan done just to check my bones. So I always say, even if you feel great and you're hitting those 50s, get the other things checked out. Especially if you have a history of your mom or father having a bad case of osteoporosis. So get that checked out. And also, it doesn't hurt to go get your levels checked out either. Just to know where you're at. You're feeling great, wonderful. Go get all those other things checked out.
And start doing strength training.
Exactly.
Strength train.
Oh, that's
And
the
eat a
other
lot of
thing
protein.
related to sleep, since we're talking about exercise. When I asked my sleep medicine specialist friend, what's the number one thing you can do to improve your sleep? You know what she said? Exercise.
Yes. Because it wears you down.
does.
You sleep like a baby.
Yeah. It says,
Honestly.
get out early in the day, get the light in your eyes, exhaust yourself, and then your sleep will follow.
Exactly. Well, we could go on forever with Dr. Karen Mann. We're going to have you back for sure because we definitely want to talk about GLP-1s. And if you want to dive in, well, then you're the one. You're the one. But, comadritas, I know that there's a lot of questions, but, we're going to try to answer as much as possible in future episodes. But if this episode resonated with you and you got some answers in, okay, then you need to share this episode like now
please
with
share.
your sisters, with your amigas, with your comadres, because not every day we have an expert, like Dr. Karen Mann. So please do that. First of all, subscribe, right? Subscribe, give us that gift, and then share this episode because knowledge is power.
Share with all the women in your life. Yes.
Sharing knowledge is what we want. And you know what?
right.
You deserve your answers. You deserve to be cared.
And this is the episode you have to watch.
Yes.
Yep.
If you are a woman, check. This is the episode you have to watch.
Check.
Check.
You don't have
This
to
is
watch
the
the other
episode.
50 plus that we've delivered. But this
Yes, they do.
is the one.
Yeah, please
This is
do.
the episode you need to watch.
This is
Yes.
the episode that will help you. You need to watch this episode.
Where can they follow you? Or how can they get a hold of you if they want to, like a one-on-one with you?
Oh, sure. So I'm on Instagram, Dr. Karen Mann, Dr. Karen Mann. I'm on LinkedIn. Those are kind of the best places to find me. And
Great.
yeah, I'm at Noom. So if you want to check out Noom and see, I do some content for them as well. I have blogs and things on women's health and weight maintenance. And
I have referred a lot of people to Noom.
Yeah. I know I work there. I'm biased, but I do think it's a really great program.
Absolutely.
Well,
Great
you're doing
resource.
wonderful work. You're
Thank
doing
you.
wonderful work. And, the fact that you obviously have shared your personal experience and now coming on board, being such a young, right? And I say young because, yes, you are young.
yes.
We are in the same age group.
We are.
But thank you for making the time. And we can't wait for you and Diana maybe one day to collaborate because I know Comadrita D here is
She's studying.
prepping for that.
I'm studying.
And we're very
yes.
proud of you. And I know that you wanted to share something in the beginning of our episode, and I'm not going to let you off the hook. What is it that you wanted to share?
I was going to share the challenges of being a non-Spanish speaker in a community that speaks predominantly Spanish and what I've had to do. And I've tried. Like I put so much effort into speaking Spanish and communicating because I do feel that patients kind of like, oh, look at her. She's trying, and they can communicate with me. And that's empowering, because unfortunately, not every provider is fluent in Spanish. So do our best, learn all the medical terms. But I was going to say when I was first training and I was in the emergency room seeing a male patient and he was anemic. So he was bleeding somewhere. And so I had to go in and explain to him that we were going to do like a colonoscopy, essentially, And I said, Señor, pensamos que está sangrando y por eso necesito o necesitamos poner una cámara dentro del culo. The whole family busted up laughing. And he was like, can she be my doctor?
Yes! I love that.
Oh my gosh.
That
I
is
mean, you didn't
hilarious.
say anything wrong.
No.
You were on point.
Bad Bunny uses that word.
Actually, but isn't that word like not something you'd say to a
It's not a
patient
medical
as their
term.
doctor?
Medical term.
But we all understand what it is.
Yes. We do.
And that's
You
what
know?
communication is about, right?
And, and Diana just said it. If Bad Bunny's able to sing it, why can't you sing
Yeah.
it?
Right.
They're like, gringa, stop. Like, no more Spanish out of you.
But I love that. I love that you make an effort to speak to so many women that need your help.
Yes.
So
Yes.
thank you.
Gracias, Quinta Comadrita.
you.
Dr. Karen Mann.
Thank you for coming on our show.
Yes.
so much.
We're not saying
you.
goodbye. We're going to say hasta pronto.
hasta pronto.
Sí.
Hasta
Okay?
pronto.
Thank you so
Soon.
much. And subscribe, comadritas, and share.
Share this episode.
Remember, this is the episode
Yes.
to watch. We love you. Mwah.
Mwah.
Thanks for tuning in today. If you enjoyed this episode, don't forget to like, share, and subscribe on YouTube or wherever you get your podcasts. We'd love to see your reviews and hear your thoughts. You can also follow Comadres Unfiltered on Instagram, TikTok, and Facebook for more updates. New episodes every Tuesday. Until next time, comadritas.